Very good morning. And I take this privilege to introduce our honored speaker, Dr. Purvish M. Parikh, sir. He is an ex-professor and head of medical oncology at Tata Memorial Hospital, Mumbai. He is a founder president of Asia Pacific Geriatric Oncology Society, president of Integrated Academic Society of Clinical Oncology, founder of Asian Cardio Oncology Society, and a founder member of Board of Directors of Asian Oncology Society. He also serves as a board member and the chair of Genetic Cancer Research Committee at Maharashtra University of Health Sciences, India. He is the emeritus editor of South Asian Journal of Cancer, International Journal of Molecular and Immuno-Oncology, and Indian Journal of Medical Sciences. Dr. Purish Parikh, a prolific academician, he has authored 20 books, 38 book chapters, and 284 scientific articles to his credit. Here I present Dr. Purish Parikh. Over to you, sir.
So we move from addiction to another addiction for me, and that is oncology. So I'm going to share some very interesting thoughts. So my father is 95 years old. And when I talk to him, these are the myths that he has. He says, I'm having a healthy lifestyle. I do not have to worry about cancer. And I did not pay attention to whatever my son is talking. You know, Ghar ki murgi dal barabar. It's always like that, right? So let's look at what is happening at Tata Memorial Hospital. Total new biopsy proven cancers registered every year is 68,000. 68,000. And they are coming from all over India. All right. So let's go to the second myth. Cancer is incurable. If I have cancer, it means I'm going to die. When I was an undergraduate student, medical oncologists also did not want to take treatment for cancer. But that was long time ago, right? So this is fortunately the photograph of the same person. Okay. The only thing that has changed is my beard has become white instead of remaining black. But the changes that you see on the survival graphs is what I have seen during my lifetime. Okay. This is all happening during my lifetime. The treatment of acute lymphatic leukemia gave a 5-year survival of 5%. And today it is 96%. 96%. So if I have seen these changes during my lifetime, all the juniors who are in the hall, they will see even more dramatic changes during their lifetime. So let me share some example. On the left side is for 3 common cancers, and on the right side is for cancers who are in stage 4 disease. And you can clearly see that the survival has dramatically improved, the chances of cure has improved. That is why National Geographic and Time magazine says that these two kids are going to survive for more than 120 years. And that is why Anand is very happy. The field of geriatrics is not going to have any diminution in the number of patients. So let me look at what is called conditional survival. And there are a lot of articles in conditional survival. So you will be surprised to see that if we live longer, our life expectancy increases. And I'm sure that all the senior citizens like me must be very happy with this. So if I'm born in 1948, my life expectancy was 68 years. Now if I'm already 65 years, my life expectancy increases to 83 years. And why I'm showing you this is because many a times senior citizens with cancer say, oh, my time is over. I don't want any treatment. Please understand their time is not over. They have still got a lot of functional life left and we should give them the best possible. Therefore, challenges means communication. And personalized medicine also means personalized communication. The government of India said that you need to propagate this information to as many people as possible. So we were given this mandate by the Director General of Health Services, and we did CMEs in oncology all across India. We had 100 top oncologists as faculty, and we used a uniform set of slides to spread the message. We also made online training videos, brought out patient information booklets, and we also developed smartphone apps that could help the patients wherever they are. So we are crossing the last mile problem. Let's come to the next myth. Cancer is contagious. So if someone has cancer in my family, I should not enter his or her room, should not eat from the same plate, or use the same napkin or towels. So when somebody like that asks me that question, I go back to my same cycle. I say in the last 43 years, from 8 a.m. in the morning till 7 p.m. at night, I'm in the middle of cancer patients. If it was contagious, I should not be alive today, right? And I think this is very convincing for them to understand that this is the wrong misconception. Another misconception is cancer is hereditary. So if somebody is diagnosed with cancer, it could be a defect in the family. And this is one of the main reasons why people want to hide whenever they have cancer. They don't want to get the treatment in time. So yes, cancer is hereditary, but in a very small fraction of patients. Breast cancer, 5 to 10%. Ovarian cancer, also 5 to 10%. I'm sure everybody knows this very famous Angelina Jolie. Her mother had breast cancer and died of ovarian cancer. Her grandmother had ovarian cancer, and her maternal aunt died of breast cancer. Obviously, this is a very strong family history, and such patients we have to be exceedingly careful. So, how do we do the testing? We do next generation sequencing, right? And this has three components: sample preparation, sequencing, and bioinformatics. And at the end of bioinformatics, we will identify what is the molecular portrait of this breast cancer that the family is suffering from. And in this particular instance, Angelina Jolie's risk of breast cancer was 87%, and her risk for ovarian cancer was 54%. So, if we have such a patient or a family, then prophylactic surgery is a recommendation that can be followed. And she has undergone prophylactic bilateral mastectomy and prophylactic bilateral salpingo-oophorectomy. So it is justified if the risk is so high. But the patient has to decide this. If everything has to be patient centric. So another myth. I do not eat outside food. I do not smoke. I don't have bad habits. Then why did I get cancer? Is God punishing me for my past deeds? So madam asked the question about microbiome. Microbiome is exceedingly important for oncology. Okay. We have millions and billions of cells. Microbiome exists in trillions. Every 1 ml of the fluid inside the colonic cavity has so many microbiomes. And we are learning more and more about the good and the bad microbiomes. And we are able to treat patients in this manner as well. Another myth is it is not possible to diagnose cancer early. If you look at rural India, 89% of patients are diagnosed in the third or the fourth stage. 89%. So, how can we solve this problem? We have to empower our patients. And in this instance, I have taken the example of breast cancer. First column is early breast cancer, second is locally advanced breast cancer, third is metastatic breast cancer. So, if a lady feels that there is some lumpish feeling in the breast and she comes for treatment or investigations, she is in the early breast cancer, less than 2 centimeters size of tumor. Treatment is surgery alone. Duration of treatment is 1 week, and cost of treatment is 30%. With that, the chance of cure is 95%. But she is afraid. She doesn't tell her husband or family members. She does not go to the doctors till it becomes 4 centimeters. Now it is locally advanced. Now instead of simple surgery, she will require surgery plus chemotherapy. The entire treatment will not be 1 week, but it will be 8 months. The cost of treatment will be increased to 2 lakhs, and the chance of cure falls down to 60%. If she waits another 6 months, it becomes metastatic disease, and you know the risk or the chance of cure comes down to 10%. So I think the biggest point that can be changed is early diagnosis if the patient and families come for treatment or diagnosis as early as possible. And this, I think, is a focus that we should definitely implement all across our country. Another myth, I have breast cancer. Surgery is a must to remove my breast. I have no chance of preserving my body image. Again, please understand this is a myth. Here is a lady with breast cancer where the primary tumor is right behind the nipple. It is now surgically possible to preserve the nipple, remove the tumor, reconstruct the breast, and give her the same chance of cure. Very, very good cosmetic surgery possible, body image preserved, psychologically very satisfying for the female. And this is also possible in other tumors. So this gentleman has an oral cavity tumor. You can see that the tumor is removed along with the teeth. And then our plastic surgeons are very, very good at reconstructing, and except for the little scar, you can see that the person has a very good body image that is preserved. So this is possible today. One more myth is about tobacco use and lung cancer. I was smoking and I got lung cancer. Now, what is the need of stopping smoking, right? The cancer is already killing me. On the left side is a photograph of a patient who was a smoker. On the right side is a photograph of a person who was a healthy non-smoker. I don't think because of pollution, such specimens exist. But the fact is that after the cancer is diagnosed, if a person stops consumption of tobacco, the survival is longer. Fewer and less serious side effects occur with surgery, with chemotherapy, with radiation, with recovery and healing, and there is better quality of life. So just because somebody had tobacco and then developed cancer does not mean that he should continue using tobacco. All patients with lung cancer or any cancer, the same all over the world, is also a myth. This is a geographical map of the epidermal growth factor receptor mutations in lung cancer. And what is their incidence all across the world? And Dr. Puri and I published this way back in 2013. If you see the Caucasian population, the incidence is only 5%. If you see Japan and Korea, the incidence is as much as 50%. And India falls somewhere in between. We have between 35 and 40% EGFR positive. The reason why I'm telling you this and showing you this is that there are pharmacogenomic variations across the world. What was used and successful in the West need not always be successful in our context. In this particular context, a drug was found useless in the West because the incidence of EGFR mutation was less than 5%. But when it was used in East, including India, they suddenly realized, oh, this is not a useless, this is a very effective drug, but in a selected population of patients. So I'm just trying to boast about what I have achieved. Most of my work has been on lung cancer, and you can see that if you do Google Scholar, my publications have been cited 13,788 times. And the top two are on the basis of work on lung cancer. And these two publications have changed how treatment of lung cancer is used today all across the world. So earlier, before these publications and before molecular testing, all patients of lung cancer were treated like what I seen on the left hand side with a combination of two drugs chemotherapy. Now we know that that was a wrong way because we did not have the diagnostic capability to identify which is the mutation in these patients. And after molecular testing, now instead of using a standard two drug combination, we now have so many combinations of drugs. And this is the reason why the chance of cure and 5 year survival has increased. So on the left side, the median survival was 8 months after diagnosis. Now, 25% of lung cancer patients are surviving for 5 years or more. Even patients with metastasis to the brain are surviving for 3 years and 4 years. So there is a lot of progress in how we are treating our patients. The cost of this is the cost of use of technology, which is contributing to 65% of everything that we have achieved today. And therefore, modern medicine is a victim of its own success. Initially, for radiation therapy, we had 3D CRT, then intensity modulated radiotherapy, then image guided radiotherapy, and now we have proton beam therapy. And this is a photograph from the Apollo Proton Cancer Center in Chennai. The cost of the treatment is 40 lakhs on this machine. Another example is CAR T cell therapy. Okay. CAR T cell therapy gives an overall response rate of 83% in heavily pre-treated patients who have no option or poor outcome. But when it first came, the cost of this single treatment was more than 3 crore rupees. So I sent an email to Novartis saying, when are you bringing this to India? And they said, we have no plans to bring this to India. So we have to find our own solutions. And you might wonder why I'm showing Formula One car racing for finding our solution, but this is very relevant. So some of you might know what is Formula One car racing. It is the fastest speed of car racing in the world. And the car has to come to a pit stop to change the wheels or to fuel up. So when it comes to the pit stop, there are 20 people working on that car to remove the wheels, put in the new wheels, add the fuel, and then allow the car to come back. Now, can you imagine what is the duration of the pit stop? The pit stop duration is typically 2 seconds. Of course, I'm joking. It's not 2 seconds, it's 2 minutes. But in 2 minutes, 20 people are working together and the car is back on the racing. So, a hospital for sick children in UK decided to learn how to do neonatal surgery management from the lessons learned from the F1 car pit stop. So what did the F1 car pit stop teach? That every person knows exactly what they have to do. They also know in what sequence they have to do, and they practice and practice and practice till they become perfect. And when this was used in the handover in neonatal surgery from the operation theater to the intensive care unit, there was a reduction in technical errors by 40%, reduction in information errors by 50%, reduction in handover time by 50%, and mortality was reduced by 38%. So please understand, we have to think outside the box. We are sitting in your center of innovation and incubation, right? This Center for Innovation and Incubation has to think outside the box to find solutions from lessons that already exist from other walks of life. So there are some examples of this, how this has worked. Ayushman Bharat provides free cancer treatment up to 5 or 10 lakhs. Yesterday we heard about reduced taxes on 17 anti-cancer innovative drugs, and therefore they are going to be cheaper by 20%. And the 3 crores of CAR T cell therapy is now available, manufactured and designed in India itself by 2 companies, Immunil, Immunact, and therefore the cost has come down to between 25 and 40 lakhs. What else can we do ourselves for our patients? So first is we have to listen to what the patient wants from treatment. As doctors, is it that they want the least side effects and better quality of life? Is it they want least visits to the hospital, or they want least out-of-pocket expenses? So we did a study on 839 survey, and this is the result. So no doubt, 70% people want the best chance of cure or longest possible survival. But 20%, 23% are wanting something other than the best chance of cure or longer survival. And therefore, we have to pay attention to this. Another study that we did across India of 373 paired samples, patient and their caregiver. And in 48%, what the patient wanted was different from what the caregiver wanted for the patient. So we have to listen to them. We have to understand what they expect in the manner that we treat them. The largest number of wheelchairs outside our hospital are where? At the airport. Why is that? We are getting older. We have difficulty in walking. But our ambition to see the world has not changed. Okay? Our expectations are very sky high. So I will focus a little bit on the older doctor treating the older, still older patient, right? And that's why Anand and I have to collaborate. So this is the Asia Pacific Geriatric Oncology Society. We have members from 20 countries and we cover 28.3% of the global population. This is a screening tool for older patients with cancer that was developed in India itself. And it divides the patients into safe score, intermediate score, and high risk score. In the safe score people, we give the standard treatment. In the high risk score, our focus shifts to providing palliative care. And in the intermediate score, which is about 12 to 15% of our patients, we did a more detailed evaluation of their geriatric status before deciding how to treat them. We also set up guidelines on how to set up a geriatric oncology clinical services. And this is the workflow that we want for the same day evaluation of new patients. A geriatric patient when coming to the hospital means one other caregiver is leaving his work to come to the hospital accompanying the person. We do not want them to waste time. Day evaluation is possible in our patients. When we find that they are compromised, and here I've taken the example of a cardiac problem, we can modify the treatment based on what is required. This is in press, and it talks about the Takotsubo disease, and that is the reversible broken heart syndrome. This is data on 35 patients from across India, 13 centers. 29 out of these 35 were gastrointestinal malignancies, and 20 out of these 35 received Folfox regimen. 8 out of these 35 died because of cardiotoxicity. Now, if we find that there is a DPYD mutation and the risk of cardiac toxicity is high, how do we modify the treatment? So this is the consensus guidelines that was published on the use of an oral medicine that replaces 5-FU with something called S1. Now, why does this S1 work different from 5-FU? Tegafur works in the liver and it reduces the metabolites which are toxic. Oxo works in the gut and it reduces the toxicity of mucositis and diarrhea. However, the OPRT that works in the tumor is unchanged and therefore the chemotherapy efficacy on the tumor does not change. That also means that the only toxicity that we now have to worry about is myelosuppression. So this is how we identify a new drug based on what toxicities we want to reduce in our patients. So I come to the last few slides. The $100 million or the 500 crore question is the future of how to treat the patient with the focus. So let's say the zebra is the patient and the lioness is the cancer. How do we do that? We empower the patient by giving a motorcycle technology. And I always end my talk with a salute to the Indian Armed Forces. We have one of the professors of medicine here who is also from the Armed Forces. We are able to talk, enjoy life, and survive because of the supreme sacrifice that they make at our borders. Thank you very much.
Thank you.
Thank you, sir.
Thank you.
Nice talk, and we could come out lot of things from your talk. Now, any questions? Sir, I have one question.
Yes, please.
A patient breast cancer treated by chemotherapy, surgery, radiotherapy, immunotherapy, etc. And after 1 year, after repeat PET scan, etc., almost nothing is there. Now the patient is on hormone therapy. The main problem, I don't know how to solve it. They increase in weight. And second one is lot of fluctuation of the, what you call, mood.
Yes.
So I have a patient, as I am a professor of medicine, they come to me as a medicine, not as an oncologist. I tell them, you better go to oncologist, they may advise, but they are behind me. How to convince them?
So this is a very important point. And when there is oral medication, this patient is on hormone
Hormonal
therapy, which is an oral medication. When there is patients are on oral medication for more than 1 year,
Yeah.
the chance of complying is reduced to 59%. So we know that your problem is not uncommon, it is a very common problem. So what we use is a visual appeal that can be easily understood by the patient. It's called the best case, worst case scenario. We say if you continue with the medicine, it is the best case scenario, your chance of cure is 80%. You want to, because of the side effects, you want to discontinue the treatment, then you are in the worst case scenario, your chance of cure drops from 80% to 55%. Now you decide whether tolerating the toxicity is good for you or bad for you. So when we put the worst case, best case scenario, a lay person is able to understand why we are insisting on the treatment. So that is what we do.
Thank you, sir. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, sir. I request the chairpersons to kindly present a certificate of participation to the guest speaker.
The chairpersons will now receive the certificates from Dr. R.M. Honutigi and Dr. Manjunath Sir, Department of Medicine.